So I think the important thing is to understand that you need to measure pain with movement either through apps, through even a pain diary. You can do it with performance tests by provoking it in the clinic. That it has to start there. And then overlaying that is the biomarkers, where we're starting to understand the influences of that pain. So I don't think we need to worry so much about utilizing the biomarkers, but just comprehending and understanding that movement-evoked pain is an inflammatory experience that is driven by the immune system in part.
Off the big stage, Corey Simon on the podcast. How was that, given the keynote?
I think it went well. We'll see. First of all, thanks for having me, Jim.
Yeah.
Really happy to be here. No, I think it went well. This is a group that I hold very high in regard. This is where I started my advanced specialization back in 2009. So I was part of this group very early on before I even went into research. And so it's kind of a homecoming. It really was exciting to be up there.
Yeah. Just before we hit record, you were talking with Derek and saying you were trying to sort of split the audience, right? Like when you talk with a group of that size, I don't know, I didn't count, 1,000, 1,500 people in there. Talking about one thing to everybody is difficult because everybody is sort of looking from their own angle.
Right.
How do you prepare for a talk like that?
You start with, I think, this is just my view, and it may be the wrong view, but I look at it from what is going to be most meaningful to the majority of folks in that room. Right, and this is a group that is highly clinical, but they're advanced specialized group that, they know a lot, and so I don't feel as hesitant to delve into some of the research granularity that I would if it was just a generalized audience, if that makes sense. And it's not to be pretentious, it's just that I know this group being specialized has had to, through their training, to delve into some pretty complex stuff. Right?
So you're like, I can skip that part, let me talk about this now, because I know you know this.
Yes.
Got it.
Or I can either say, you know this, or I can delve into there and they won't glaze over, right? So as far as, it's almost splitting, it's more splitting it's like threading the needle, I guess. It's like being meaningful to them in a group that is going to need to use this on a Monday morning. And because I'm now 95% a researcher, sometimes that's difficult in a clinical group.
Yeah.
But I am a country boy that started off in a blue collar city and training and then ultimately treating. And so I've been in realms where I feel very comfortable, much more than in my research space often. I love coming back and working with folks that are actually seeing patients as opposed to having to write grants and So it was not. I thought it was going to be difficult. I'm hearing it wasn't. It was well perceived and it wasn't as bad as I thought. So we'll see when
You didn't get beat up on the way out, which is always good.
I didn't yet. No.
Not yet.
No.
It's a manual therapy conference.
Yeah.
It's still early. All right, so let's talk about what you sort of alluded to. You've moved from treating pain with your hands to decoding it in blood. Do I have that right?
Yeah.
So what convinced you that biomarkers could change how we think about musculoskeletal pain?
Yeah. I'm going to go all the way back to where I started. So my grandfather's how I got into pain. He, 85 years old, around the time he started just being terribly treated. This was the opioid epidemic. He was just overdosed with opioids, and being older, that's not a good thing. And his pain was no better. He was having surgeries very late in his life. And he, at one point, said to me, he said, "Kill me now." And that's where I said, okay, we are doing a very poor job of this. And I decided I was going to devote not just my time to clinical care, but to pain and understanding pain in older adults. I did my FAAOMPT in 2009. Started to get these skills, but it's the Dunning-Kruger effect where the more you know, the less sure you are of yourself. And I also had a lot more questions than answers, and I realized that the pain research just wasn't there for actually making meaningful changes in patient outcomes, specifically for older adults with chronic pain, right? And so that's where I went to Florida, worked with Steve George in his lab, and was really devoted mostly to sort of physical therapy and manual therapy as the interventions. But then I started to work with some pain psychologists, and because I was interested in pain and aging, and these folks were pain and aging psychologists, I should say, that's where I started to delve into what they were doing, and they were into the biomarker space, and realizing that, it's this interaction between the neuroendocrine system, the immune system, and the sensory system of pain. And collectively, this crosstalk, which, by the way, we can measure by blood, it's right there for us, we can then institute these little stimuli, like a provocation test, like, heat or cold pain, or we make them do a painful movement, measure blood before and after, and see how those markers change. And those markers are a reflection of what the systems are doing in the body.
And different for each person to person, I'm guessing.
They are different for each person, but what's also interesting is that in specific conditions, there's can be similarities, and we can then use those as a way to say, you know what, you are at risk for this condition or this poor outcome. That gets into the precision rehab space, which is what we're trying to figure out. To do so, this is then bringing on rheumatologists and biomarker researchers, and so my interactions have moved into that space now, and it's really more of a team science approach, because I didn't train as a molecular biologist, right?
Me either.
Yeah,
I didn't either. How close are we for PTs to being able to use this in the clinic? Like, is that?
That is a fair question. I don't know. I think that what's very exciting, let's back up to like some of the precision rehab stuff. I think we're closer, i.e. determine folks that are at risk based on certain presentations, like if they have pain in one region and another region, like the hip and the low back. That's a bad recipe, and we know that's a group that's at risk for decline, and we know that we can target with hip as opposed to traditionally going with the back. We actually think they'll do better. That's Greg Hicks' work out of Delaware, and so that realm we're doing better, the precision side. As far as biomarkers are concerned, I don't know. I'm a realist here, and I think that we're still trying to get funded for a lot of this stuff. We're excited about it. If I'm being fair, what I think is going to be the way it ends up is that we see these changes in biomarkers in our studies, and then we see how they're correlated with self-reported measures and different types of measurements that don't involve having to draw the blood, and then we can determine, because of that correlation, that that's a group that's at risk. Does that make sense?
Mm-hmm.
So I think we're there. I think it's also not just going to be PTs. I think it's going to be physicians and surgeons. I think it's going to be more of that team science or team clinician interdisciplinary approach to care that we're going to have everybody a part of it. It's not just PTs.
All right. Well, how do you see manual therapy, since we're at a big manual therapy, around manual therapists, how do you see manual therapy fitting into a future where treatment might be stratified by biology as well as by movement?
Yeah, so I think that it is very important to lean on non-pharmacologic interventions. I am a manual therapist at heart, and we use it in our studies. And so it's more so using those specific interventions as a means to create this very robust type of care. And so I see manual therapy being used more to target for specific conditions, for specific patient populations. So it's in part of like 3 or 4 of our studies right now. What we don't know is the extent to which we need to cater it specifically for like pain mechanisms, and that's some of the work that Chad Cook's doing and others here. And so I don't know how that's going to end up, but I think that's where we need to go. So I think manual therapy is always going to be there because it's a strong intervention. I think cognitive behavioral interventions coupled with that's even stronger. Exercise coupled with that's even stronger, I think. And then I think there's also some specificity based on the patient, right? Like, what does the patient ascribe to? What do they have good responses to? And so it's always there. It's in our studies. It's just we have this overlay of biomarkers that we're looking more so at the physiologic responses, essentially.
Yeah, bridging that gap, which we love to say in healthcare.
Yep.
You mentioned before you earned your FAAOMPT 17 years ago. What did it feel like standing on stage now as a keynote in front of everybody here at the conference? What changed most in how you define manual therapy since then and now?
Yeah.
I mean, that's 17 years. That's most of a career.
Yeah. Well, for first, I black out usually when I'm on stage. I don't remember. It's a little bit the Will Ferrell thing, but
come to when you're walking off and there's clapping.
What happened? No, I think that it has changed a lot. When I was here then, and it's not better or worse, it's just that, as you know, when you leave school, half your textbook isn't even applicable anymore, right? It's that old adage. And so I think what we were thinking about is more so the physiologic changes is more the emphasis now, as opposed to back then it was more the biomechanical changes. Now so what I mean by that is, that you have to move this facet versus now it's by doing that sort of manipulation or mobilization that's affecting this specific region that has nerves, but it also has immune markers and so on and so forth. So I think it's more of a neurophysiologic phenomenon as opposed to a biomechanical phenomenon by itself. But I do think if you look at Joel Bialowski's paper from I think 18 that we worked on, is that it's expansive, it's everything. And so that wasn't there when I was here 17 years ago. We weren't talking about neurophysiologic phenomenon. It's almost old news now.
Sure.
But I think that's where we are now, and that's what I think was particularly exciting, is walking out to see like just glowing faces. Some folks come up to me and talk about like, that's cool, let's talk about that. I'm like, okay, we didn't do that. We didn't do that 17 years ago. So I think, and it's by nothing I did. It's just that people are receptive to and understand how pain works now, and that's what we need to kind of get out, not just to specialized groups like AAOMPT, but to PT and rehab in general.
Yeah. All right. So for a clinician listening right now to you, who may have or never touch a test tube, what's one thing they can take from your work and apply it to older adult patients on Monday, like you mentioned?
It's the move evoke pain piece of what I do. So it's that if you are measuring pain, asking them what their pain rating is, and whether sitting in a chair on a plinth, you're doing them a disservice. You basically have boiled down their pain experience to a unidimensional measure that it's no surprise they'll say 12 out of 10 or 13 out of 10, because they're trying to convey to you how much it affects them. So I think the important thing is to understand that you need to measure pain with movement either through apps, through even a pain diary. You can do it with performance tests by provoking it in the clinic. We've shown that there's actually some strong correlation between doing it in the clinic versus an app, so you can use one or the other, we think. That it has to start there, and then overlaying that is the biomarkers, where we're starting to understand the influences of that pain. So I don't think we need to worry so much about utilizing the biomarkers, but just comprehending and understanding that movement-evoked pain is an inflammatory experience that is driven by the immune system in part. So just if you have that conversation with your patient and they're not thinking about it from, well, it's this joint or it's this nerve, it may be a part of it, but we also know pain is way more complex than that.
Yeah.
So for the patient, or excuse me, for the physical therapist to utilize mood-evoked pain measures and to have the know-how about where pain comes from and that it involves the immune system, it involves the neuroendocrine system, it's more of this holistic phenomenon, they can convey that to the patient, and the patient then can understand pain a little bit better. Because then they're not going to have that surgery necessarily that may or may not work. Maybe they're going to go with another, conservative treatment first and see that. And so I think that has to change the narrative. That's what happens, as opposed to just doing a biomarker test. All
right, we're going to wrap up with something we do often, which is called the parting shot. What's the last thing you want to leave with the audience who is listening here, who's not necessarily at the AAOMPT conference? You can't have multiple priorities. What's the one priority? What's the one thing you'd leave them with?
It's a little bit negative. It's not negative from a standpoint of this is an invested group. What's a negative is that we are on the horizon of a major epidemic as opposed to chronic pain. Our population's getting older. There is inequities and disparities in care. And I think we need to do a really good job of not only knowing the evidence, but coming together to standardize how we treat patients. And so I think it's more a parting shot to all the clinicians to come together and say, let's band and address what's coming on the horizon, because those paying into Medicare are going to go down. Those that need the care are going to go up. And so it's going to fall on us to actually have good patient outcomes. We can't do that by ourselves. We need to band together.
Love it. Corey, appreciate you walking off the big stage and onto our podcast stage and having a chat with us, man.
Thanks,
appreciate
Jimmy.
it.
Good
Thanks.
seeing you.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.